Yeah, okay, so a bit about me. Yes, I'm a general internist with a clinical interest in palliative care. Um, I would say I'm leading the palliative care effort at my hospital because we don't actually have a palliative care program, which is actually very rare for any hospital in the Toronto area not to have a palliative care program. And the hospital that I work at is over 700 beds, so it's a very large community hospital with an oncology program and sort of a lower socioeconomic patient population. So it's a very highly needed area of focus that's definitely missing right now, but will be developing in the coming months, and I'm certainly going to be a part of that. What I was going to talk about today is, yeah, I'll pull up my presentation. There we are. So you can see that okay? All right. So I was going to talk about goals of care. I mean, the first disclosure that I have really about this is I have no idea what terminology you'll be familiar with and what you're not. So you have to stop me if there's anything that needs clarification. I'm just switching my settings here a little bit so I can actually see things. Sorry. All right. So goals of care. So yes, as a general internist with a focus on palliative care, the idea of goals of care is really around the immediate decisions that patients make with respect to their health care. So most commonly referred to as DNR. We've sort of expanded to goals of care because DNR is really just one element of it. And I thought I would just share my experiences in Canada because truthfully, I did medical school in Israel, but I really have no idea how things work in Israel with respect to these types of conversations. I think what happens in Canada is probably pretty similar to what happens in the US because the trainings and the culture they're so similar. So anyway, I'll give you a bit of a sense of how I see things. I really have no disclosures or conflict of interest. The only disclosure I have is it's 9 a.m. on a Sunday morning in Toronto, so I can really not guarantee no disruptions. And I've got kids running around in the background, but I've bribed them to the best of my ability to keep quiet. I thought I would just also take a second to talk about how the goals of care process works in Canada and why this is or North America and why this is so important to me. Right now, when you admit a patient, and the way our healthcare system is set up is a patient is seen by the emergency room doctor and then referred to internal medicine, who then decides on admission. So the emergency room doctor doesn't just put the patient in the hospital, they have to first refer to internal medicine. And as an internist, we then decide whether or not a person is to be admitted to hospital. Front and center to that admission process is always the goals of care, is always the DNR status. And you hear it in physician handover, you hear it in nursing handover. It's sort of like, age of the patient, one liner on why they're in hospital, and their code status. So there's this huge pressure to make sure that's established at the time of admission. And all through residency, this also comes up, what's their code status, what's their code status. And so, we're really encouraged to make sure that we establish this information right at the time of admission to hospital, which makes a lot of sense because if something were to happen in hospital, we really need to know how to proceed. But there's a lot of flaws in the process, and that's really what I was going to talk about. Really, all through residency and my independent practice, I just felt uncomfortable with the topic in general. And it wasn't so much the content, but it was really the process. And the main problem I had is no two people shared the information the exact same way. And so I would see these conversations and I would just feel like, had I been the one to be presenting the information, maybe the decision on the side of the patient would have been different. And that has always been a bit of an ethical dilemma for me, because if we're relying on patient autonomy, then we have to rely on the consistency of information in order for patients to make decisions. So when you have a process that's so highly variable, how can I really trust that a patient is hearing the information as the way that they should? And this is our do not resuscitate form. This is through the Ministry of Health. It's a standardized form. A lot of patients are encouraged to have this attached to the refrigerator. So if 911 is ever called and the paramedics come into the house, they see this immediately up on the fridge and they know how to act. But it's a very vague document. There's not a ton of content in there. And what the documentation lacks is any context for how decisions were made. So you don't really know how you would apply this exact information in different circumstances. So for example, if I have a 95-year-old person who has a cardiac arrest in their home and they have this form on the fridge, and I know do not do CPR to resuscitate them, that's very, very easy. But what about, and just from personal examples, what if there's a 65 or 70-year-old patient who recently had a hip replaced and accidentally overdoses on their opioid medications and has respiratory depression, decreased level of consciousness? Well, on this DNR form, I don't know if you can see my cursor, but on this form, the last point here of do not resuscitate is advanced resuscitation drugs such as, but not limited to, pressors, antiarrhythmics, as well as opioid antagonists. And so if I were to respect this document as it is, I would not be resuscitating this individual because clearly they've signed a form that says do not resuscitate, and that includes opioid antagonists. But I'm absolutely certain that this person did not have a conversation about the accidental excess use of opioids. And do I want to be responsible for the death of an individual without knowing any context or how this form was signed? Another example is I had a patient who came from a homeless shelter who was in alcohol withdrawal, was having a status epilepticus, and healthy guy otherwise, with the exception of his alcohol addiction, healthy lungs, and he needed to be sedated and he needed to be intubated and he needed to be put into the ICU. And again, he came in with one of these forms that would have said, maybe don't do CPR, and that's not what he would want. But I really didn't know if it applied to that context. And in this situation, I actually reversed his signed DNR, and I said, I can't take responsibility for the end of this person's life without knowing more about how he made the decisions that he made. And the ICU was not pleased with me, but I felt that was the most ethical thing to do. What's even more challenging is that sometimes we infer the conclusions that a patient has made, and we do this not out of malice or bad intention, but just out of patterns that we recognize. And so sometimes we'll see a patient who has a DNR formed, they'll be in the emergency room or in the ICU, the blood pressure will be running a bit low, and then we'll be approached with, they're a bit hypotensive, should I bolus him with some fluids? He is DNR. And if you're assuming that the logic of a person's DNR is that they are ready for the end of their life, that they're sort of complete with the life that they've had, then sure, maybe that makes sense. But we don't actually know why they've made that decision. And somebody who's had no plan for resuscitation could certainly be appropriate for IV fluid bolus or antibiotics. So, once we start making assumptions about why this form was signed, it can be even more problematic. The other thing is what goes into the logic of why somebody would sign a form like this or make decisions about their healthcare really sits at the apex of all of their decision making. It's really central. So, because what you're talking about is really the end of someone's life and the circumstances in which they would want to live. A lot of people interpret this as how a person would want to die, but really what goes into making this decision is the circumstances in which they would want to live, not how they would want to die. And understanding that and having that information available applies not just to resuscitation status, but it also applies to all clinical decision making that they would ever make. It reflects their philosophies. Of course, that information can't go into a single form like this, and no paramedic is going to come to the house and read a whole essay on why a person has personal philosophies towards their healthcare and make decisions accordingly. But the absence of that information really can be a little bit paralyzing in helping to guide people through healthcare decisions. Just some definitions. So advanced care planning, and sometimes advanced care planning, goals of care, in our terminology, they're used a bit interchangeably. Advanced care planning is really a process of reflection and communication around the values and wishes, all the what if questions. What kind of healthcare would you want in the future? Would you ever want to live in a nursing home? Who would be your substitute decision maker? These are sort of broad global decisions that a person is encouraged to make. And the goals of care are specific, concrete decisions about care and treatment. So, within the context of a cancer, would you want to have chemotherapy? Or if your lungs were to fail, would you want to be intubated? Those are the goals of care. At their best, goals of care are established early in disease trajectory. They're meant to be exploratory. They're meant to be conversational. They're meant to be longitudinal, which means you revisit the same topic again and again. And really, they're meant to take time. These are hard conversations just to have in one shot, unless a person has already talked about their personal belief system, which certainly occurs. But I would say in a minority of the time. The majority of the time, people haven't thought about this before. They've sort of bought their life insurance policy, but not really put any thought into all the different circumstances of how things can unfold. And at their worst, this conversation is done during a life-threatening crisis. They can feel very pressured. They can feel uninformed. They can feel almost transactional, like you're bargaining in order to establish a DNR. And they can feel adversarial, like the doctor is really working against you in order to establish something. I say the doctor because in our healthcare system, it really lands on the doctor to have this conversation. And sadly, the at the worst scenario is probably the one that I see more. Again, my bias is that I work in a hospital, but just knowing what I know about the practice of family medicine in this country as well, these conversations are not happening upstream nearly enough. They're happening when people come into hospital and they're acutely unwell. The benefit to having this conversation doesn't just benefit the patient. I mean, it certainly benefits the patient. You give patient autonomy and control, but it also hugely benefits the healthcare system. Preventing admissions and readmissions is a huge amount of healthcare dollars that are spent on providing patients with care that they don't necessarily want. It also helps the family and open communication, and it helps the care team and making sure people feel confident in the care that they're delivering. So there's a ton of advantages to doing this properly. We're a little bit behind in the process and figuring this out, and we're doing it a little bit too late. So if I were to present a case, this was one that I had not too long ago. This was a 92, this isn't him, but this is a 92-year-old who came to the hospital through the emergency room. He'd had a fall and a leg injury. He was a delayed presentation because he was such an independent and functional person. He was like, okay, fine, my leg is a bit sore, I'll deal with it later. He did have a complicated medical history, but at his baseline, he was highly intelligent, independent, cognitively intact. He was admitted to a medical ward and suffered an MI, an NSTEMI, and I was running the telemetry floor at the time, so he was transferred to my floor on telemetry. And when he was transferred to me, he was in multi-organ failure, and the goals of care conversation was to commence for the first time with me. Oh, and by the way, his children are lawyers, which is just like the sugar on top, because that just adds one more level of trepidation, fear for lawsuit, and you come into the room tremulous because you don't know what you're walking into, and we tend to be a little bit more afraid of lawyers. So, you want to be very cautious to handle this right. I'll come back to the case after. This is I don't know if people are familiar with this graph, but this is just a very sort of broad depiction of how it is that people die. The first trajectory is, you have a catastrophic event and you drop dead. That's today. In the olden days, pre-hygiene, pre-medicine, that's pretty much how everyone died. You sort of lived your life and then one day you drop dead. And as doctors, it probably would have made our job a lot easier. You don't have to deal with a chronic deterioration, clinical decline, and philosophy of care and all this. People they died quickly and suddenly. Trajectory 2 is, with more diagnostics, more therapeutics, but even think of aggressive cancers, even the more indolent or terminal cancers, a similar curve that might be drawn out, but a short period of rapid decline. Trajectory 3 is the chronic disease category, the CHF, the COPD, renal failure, acute dialysis starts. And each hospitalization drops you a little bit down from your baseline. And you have these sort of dips and then returns to a steady baseline and then dips. And then over time, you just reach the terminal phase of your disease. And trajectory 4 is our prolonged dwindling, frail, sometimes patients with dementia, slow decline, we call the dwindles. And interestingly, it's sort of our best case scenario for how all people want to live. I mean, this point on the graph of death is, the ad 120, this is the 120 point where you've kind of declined slowly and you get to that point. It's not entirely appealing either. As a side, I don't know if this is commonplace in Israel as an expression, but I had a patient recently that I had said ad 120 to, obviously he was a Hebrew-speaking patient, and he corrected me and he said, no, ad 120. I should live to 100 like a 20-year-old. I'd never heard that before, but I thought it was really fascinating. Let's see. My slides moving here. There we are. Okay. So in internal medicine, critical care, this is where we see a lot of the patients, and we see them during these dips. And it's important to us because it biases us in an enormous way. In my experience, it biases us because we only see them during those dips. We don't see them during their periods of wellness. And that anchors us to a perception of this patient where they are constantly sick. And truthfully, it bothers us as healthcare providers, especially when they're repeatedly admitted to hospital, because it's inevitable that we'll start to say, who would want to live like this? The person's constantly sick. Or it can sometimes even be personal. We did so much for them on their last admission, and we talked to every member of the family. We put in supports at home, nursing, personal support workers, a hospital bed, all this equipment, and they just come right back to hospital. What a waste of our time. What a waste of healthcare resources. And even hospital administrators, they get annoyed when patients get readmitted again and again and again. But the problem is, we don't see them at the point where they're actually on their line. We see them during the dip. We don't see when they're feeling relatively well, when they're enjoying some quality of life. We only see them when they're sick. Now, our College of Physicians has a framework for how to have conversations around goals of care. And there's some specifics about how to do it and when it should be done, but it's really designed for the outpatient setting. And you would think that goals of care would be the same whether it's inpatient or outpatient, because they're meant to reflect the core values of a person. But the reality is the hospital is a very artificial environment, and it doesn't reflect what a patient's day-to-day looks like. We look at patients a certain way, whether we like it or not, and it's a bias that's very, very hard to overcome. We put all patients into the same gown, we put them all into the same looking beds, and there's something about a patient in a hospital gown that just makes them appear a certain way. And if you've ever had a family member who you've seen in the hospital in a hospital gown, they look funny when you see somebody who you know to be very independent, or even a parent or somebody who's a strong figure, and you see them reduced to this individual in a gown, kind of clumped together with this notion of how all patients look. Or if anyone has ever been admitted to hospital and worn a hospital gown, I've had that experience. I can't wait to get out of it. Um, you know, as healthcare providers, do we describe ourselves as good patients? Probably not. And I think the reason for that is, even if it's subconsciously, we are constantly in a fight to break away from what we know is assumed of all patients. And we don't want to be categorized with the rest. We want to be distinct. We want to be separated. And that's why we make bad patients. But it's imperative to acknowledge this in medicine, and especially when it comes to goals of care, because you can't see patients as patients when you're talking about goals of care. You really have to see them as people. You have to see them as your parents, as your siblings, or as your friends. You have to see them as yourselves, because really they are us and we are them, and there is no difference. But when you frame it in that way, and you frame their goals from the perspective of being on the line rather than being on the dip, it gives you a much more accurate representation of what it is that gives a patient a good quality of life and how it is that they make their healthcare decisions. I think the biggest failing around these conversations, as I described it in our practice here in North America, is typically this is done in the emergency room. But I think the timing is probably the biggest issue that we have, and that's probably where we're coming at this the wrong way. It is the worst time to have a conversation during acute illness, and it's even harder to do that with a substitute decision maker than it is a patient themselves. And that's because the stress of acute illness it obscures your judgment. There's no way you can think clearly when you're also fighting to breathe or fighting with the notion that you might die. A person might want very aggressive measures, and they don't understand the implications because they're fighting to restore the quality of life that they had previously, even though that might not be possible. That's what they're trying to achieve. And on the other side, we sometimes have patients who express the wish for end of life when what they're actually asking for is symptom relief. We even have had patients who ask for medical assistance in dying, or hamatat chesed, which is something that's legal and available in Canada. And really what they're asking for is just relief from their pain or from their breathlessness. And so I like the approach of a birth plan. Again, I don't know if that's something that's commonplace in Israel, but birth and death are sometimes related because they're described as the two times in your life where you live an incomplete day, where you don't make it a full 24 hours, which makes it by definition impossible to plan for with guaranteed uncertainty. Now, a birth plan, which I only learned about when my first son was born, we did these birthing classes, and the instructor had us do this exercise where she said, "Imagine a continuum from the door to the window. The door is put an epidural in a parking lot. I want to feel nothing. I want this to be absolutely a painless experience from the door. And to the window is I want to feel everything. I want a completely natural birth. I don't want anything that's going to blunt that experience." And the instructor had all the partners go stand up on this continuum where we felt our personal philosophy was, and then sit down. And then she had all the expecting mothers go stand on the continuum. And there was some alignment of the partner and the mother. And there was one person at the window, one person at the door, and everyone was laughing and thought it was a really fun exercise. But the point that the instructor made was it has nothing to do with your birth plan, because there's too many variables in your birth plan, and it's almost impossible for the birth to go as planned. The importance of the birth plan is the discussion around philosophy, because when a person is in labor, they're not able to make decisions for themselves. They're distracted by acute, it's not illness, but an acute event. And so what they really need is the people around them to understand their principles and their philosophy so that they can make the decisions for them. And just sitting in this class, I thought to myself, my goodness, that's exactly how end of life care needs to be as well. It's not so much about what happens on that day, but it's about having these exploratory conversations and discussing with your family around the dinner table, not in the hospital, so that everybody knows what your principles are. And when the time comes, they can act on your behalf. So, with this case, this patient was transferred to me. I knew his prognosis was grim. I mean, he was already in multi-organ failure. I knew this man for a total of 30 minutes before he died. And in that 30 minutes, I needed to meet his lawyer son. He was fully unconscious, the patient. I needed to establish rapport. I needed to provide medical updates. I needed to explain the prognosis and establish the goals of care, because up until this point, this man was for full resuscitation, which would have meant CPR and intubation in the works. And there was no chance that he was going to survive. But this is what had to happen in 30 minutes really should have been happening over 10 to 15 years, by the time this guy, average life expectancy in Canada is 85. These conversations should be happening well before 85, but certainly after 85, once you've hit the average life expectancy, this should be well established. And then I'll get these calls. The nurse will call me and they say, "Can you please review the goals of care?" I get summoned. And this is where it gets very, very complicated for me, psychosocially mostly, because the goals of care, which are meant to really define how a person wants to live, now I'm really being asked to describe how they want to die and to establish how they want to die. And patients really aren't ready for this conversation if they've never had it before. The other issue is that I wouldn't be asked to have this conversation if the patient were medical care. Nobody wants me to go and explore the goals of care unless they're full code. And that makes this a little bit transactional. It makes it a bit pejorative. It makes it so that I am out to get the DNR. They're not really asking me to expand on the goals of care. What they're saying is you need to change the goals of care because this person is going to die, and we don't want to put them through a very aggressive resuscitative intervention. But the biggest problem for me is I now have to go in to have a conversation with someone who's never talked about this before. And it's not that they haven't talked about it before and they've never thought about it before, because I'm absolutely certain that anyone over the age of 15 has thought about their own death and has probably spent significant time thinking about their own death. So somebody at the age of 92 has almost certainly spent a good number of decades contemplating what their death could look like. And it's a very heavy, deep conversation to have, even without the pressure. And it's even harder with a substitute decision maker. So in this case, I had to talk to the son, who'd also never had this conversation, who now has to reflect on his life with his father and all the experiences that he had. The psychological depth of jumping into this conversation is really, really impossible to understate. It's a very, very complicated and challenging thing to have to do, especially when it's in the acute environment. And so, now I get this goals of care is really just a surrogate for DNR. the cases that I described earlier is, sometimes somebody comes in with this form signed and we're almost lucky to have this, but we're only lucky for the sake of convenience. I often find it harder. I see patients who come from nursing homes who come in with this signed form, and that signed form might be from, 15 years earlier, where I have no idea what's happened in the interim. And sometimes I've seen this form signed on the day of transfer to the hospital. And that really makes me uncomfortable, because then I'm absolutely certain that this conversation wasn't done properly or in the right context, because they're acutely ill when it was signed. So, in the interest of not complaining about everything that's wrong with the system, I wanted to come up with some solutions. And in order to come up with solutions, I first had to go through everything that I saw as problematic, and a bunch of the things that I've mentioned already. But this was the list that I came up with. The timing. So, we expect way too much too soon. Having these conversations in the emergency room is just completely unrealistic. And they need more than one sitting. So the expectation that you can just have this conversation in one shot, also, it's unrealistic. The lack of training. I mean, we receive none. If anything, it's the opposite. When I was a resident, if there was a complicated family meeting that had to take place about decision making, usually my staff would say to to me, don't bother to go to that. That's going to take up a ton of your time. Go deal with the acute patients. It's more interesting for you. So we get shielded from these types of conversations in our residency training, and then walk out into independent practice and have it sort of tossed onto our shoulders. There's no standardization in language or in process. And one of the biggest challenges that I see is there's a huge discomfort with certain words, mostly the words death, die, mortality, end of life. We tend to avoid these things. Some of the provinces in Canada have moved away from the term DNR completely, and they say AND, which is allow natural death, as opposed to do not resuscitate, and they find that that's a little bit more appealing and easier to understand. The next point, the professional failings. We are trained to see death as a failure, and our clinical trials, the primary endpoint is survival, years of survival, months of survival. We take quality of life into consideration, but generally the goal is live as long as possible. We've had patients who say, or the families who say, "Oh, you can't talk to them about that. That's going to kill them," or they'll give up hope. Or that's how patients feel. It's how families feel, and honestly, it's how doctors feel. And I think when you avoid a certain subject, or you dance around what you know to be inevitable, patients, their families, they pick up on that avoidance, and that allows them to avoid as well. And that a lot of that has to do also with the language we use when we talk about some of the euphemisms for death, the gentle ways we can let people down. Oh, it's almost their time, or they might pass soon. And those, they sort of dance around what we're really talking about. And that dance leads to this interaction with patients and their families, where they think, oh, if they're not really using the words, then maybe they think there's still a chance, and maybe we can keep fighting. So I find that the language is really difficult. We have biases as healthcare providers. I mean, we see people die all the time. We know how to recognize an imminent death. We see when a deterioration is going to lead to death, but families don't. What families see is their family members who are almost exclusively fighters. I've never heard a family say, well, they're not really a fighter, so it's time to die. No, grandma is a fighter. It doesn't matter if she's Jewish or Italian or Muslim, whatever. They're all fighters, all these people. System pressures. I mean, COVID brought a ton of this. Lack of beds, physician burnout, access to ventilators, the media pressure, and then of course ethics, religion. It's always tough when you invoke religion into decision making. People use religion in all sorts of different ways, and lack of documentation. This is for me, this is a major one, which is that even after you have this conversation, even after you get through all of this, if you don't have it documented properly, then there's no way to establish continuity. You can't start a conversation that finishes in the doctor's office, for example, or finishes at the time of the next admission. And the result is that you have a ton of interpractitioner variability. You have different doctors who have different practices and different approaches, and therefore you have variability in patient decision making as a result. And that leads to repeated conversations again and again and again. Angry families who start to feel like you're after something. Like, why do you keep talking to me about this? I already said what I had to say, but I don't know in what context that was said. So I raise it again, and so does the next doctor and the doctor after that. And probably the worst result is that you have care that's discordant from what a person actually wants. If you were to have this conversation properly and establish the true goals of care, then maybe we wouldn't be providing the care that we're providing because it's not the same as what the patient wants. And if we can't figure that out properly, then we run the risk of doing things for people, but to people who don't necessarily want that. Now, assuming we get it all right, and we have these great conversations, and we document everything perfectly, and we've been talking about it at the dinner table for years, and this is exactly what they want. Families can still make the quote unquote wrong choice, wrong in the context of the patient, not wrong in the context of the doctor, but families can still make the choice that's opposite to what the patient wants. And why do families who acknowledge that patients who would never want to live in this way, why do they still push for the most aggressive measures? Well, there's still a ton of variables at play. There's still the long distance decision makers, there's still religion and cultural norms. It's very, very hard to separate what you want for a loved one from what you think they want for themselves. Guilt is a very, very powerful emotion. Lack of control is difficult to handle. The feeling of helplessness because you're doing nothing. Don't just stand there, do something. There's always something that you can do. But usually it just has to do with knowledge. There's something that the patient or the families know that we don't know, whether it's religion or family experience or fear. There's something that we haven't explored properly that's guiding their decision making. And there's something the families and the patients don't know that we do know because of our experience. We know the outcomes, we know the procedural details. We know about the safety and the trajectory of what's going on, but the family doesn't. And so usually it's a combination of these two things. And so even if the process is done beautifully, there can still be failings. So, I mean, I have my own personal tricks. I guess this is completely anecdotal based on my own experience, but these are a few things that I have found effective. So clarity, we tend to approach death as though it's a possibility when really it isn't. We know it's inevitable, but when we're talking to families, we're talking about death, end of life, mortality, and we have to use those words because my experience has been that our avoidance leads to their avoidance. And it's not easy to use the words, but with practice, it does get easier. And I will sometimes ask patients or their families, they'll say, what is the plan for their death? What's the plan for their end of their life? Where are they going to die? Who's going to be there when they die? What do they imagine their death will look like? And people have the most phenomenally descriptive answers to that question. I had a patient maybe 2 weeks ago tell me that what they pictured for the end of their life is that they'd be lying comfortably on their bed. There'd be a bouquet of flowers at the bedside. The light would be flowing in through a stained glass window, sort of illuminating them. I mean, they had a perfect image of what their death would look like. And from that conversation, I was able to say, but if that's how you picture your ideal death, then these are the steps that we can take to achieve it. But the idea of intubating a patient, putting in a G tube, having them in a hospital bed with tunneling sacral ulcers, that is not consistent with what this person sees as the end of their life. And so just asking the question and having clarity is really, really helpful. The other big thing for me is normalization. So when I have this conversation, I don't start with the death part of things because then patients feel, and understandably, that I know something that I haven't told them about what's coming. So I start very neutrally in a line of questioning that really could be asked to any patient that comes into the hospital. I start with, who is your substitute decision maker? If you were ever incapacitated, say you had a bad car accident or something else, who's the person who makes the medical decisions on your behalf? And if once they identify that person, I then say, have you ever given them any guidance on how to treat you in those circumstances? Very neutral sounding questions. And that allows me sort of a launching point to get into, well, what do you mean? Well, did you ever think about if you would want machines to keep you alive, or if you would want to live if you couldn't walk, or those types of things. And that allows me to sort of fill in the gaps, but keeps it in a very neutral and calm way and very sort of exploratory as opposed to targeted. The role of a substitute decision maker is really taken for granted. a person is incapacitated and we just look to their next of kin to make medical decisions. But like I was saying before, it's very hard to separate what you want for your father, for example, from what you think your father would want for themselves. And a substitute decision maker really needs to be explained how to make decisions on behalf of another individual, that they really need to think about the context of what the other person would want for themselves. And particularly in patients with dementia, where there's been sort of a slow clinical deterioration, framing it in that way allows them to take away the responsibility from themselves and think about what the person will want if they were able to make the decisions. And it takes away a lot of the pressure. But substitute decision makers don't really know how to be substitute decision makers. And then documentation, as I mentioned as well. You know, the way it happens in our system is patient gets admitted, the physician at the bottom of the note will say, discuss goals of care, the patient is full code. But I really have no idea what it went into that conversation. So having an expanded form of documentation really, really is important, because when these patients come back to hospital at a later date, I need to be able to see that information and expand on it. So those are just some of my anecdotal tricks. The other thing that I do is I separate out the interventions that are life supporting from those that are life restoring. I think when we lump everything together as DNR, it becomes very confusing. And people think of CPR as sort of like going, CPR, gone. And truthfully and medically, that's not actually what CPR is. CPR is what we do when a patient's had a cardiac arrest. And by definition, if your heart is not beating, you are deceased, you are dead. And so really what CPR is, the person has died and we are trying to bring them back to life. And I find that it's a very, very important distinction, because when it's separated out from life support as its own entity, oftentimes patients who are satisfied with their life, who don't really want to be alive anymore, are comfortable saying, no, if I die, I'm fine with that. And people should have the autonomy to make that decision. There's a concept of, you know, what is clinical depression and what is true death readiness. And there is an entity of people who say, I am ready for the end of my life. And when we've really learned that the most has been in the medical assistance in dying, or the euthanasia practice that exists in Canada. We have a lot of patients who just say to us, I'm perfectly fine, I'm content, I'm complete, I would just like to die. And so I find separating these things out are very important. Actually, even separating it out sometimes leads to more in-depth conversations and patients who actually say, I do want to die, you know, whether it's comfort care in a hospice or a palliative care unit, or whether it truly is for something like physician-assisted dying. So what is CPR? I always ask patients to tell me what their understanding is. Of course, it's always better to explore their understanding of their condition before you start teaching them. And so, of course, they did a study on this, and they reviewed a bunch of shows in the 90s. It was ER, Chicago Hope, Rescue 911. They didn't include Baywatch, which probably would have obscured the data significantly. And, you know, because if you ask a person if they know what CPR is, often their impression of what CPR is comes from the television. Most of them haven't seen chest compressions in real life. And so when they reviewed, I think they reviewed 97 episodes. They looked at 60 occurrences of CPR in 97 total episodes. And if you could guess what percentage of patients undergoing CPR in television survive to discharge, I don't know if we have to, anyway, we don't have to use the chat. I can just get to the point, but in the television, 75% of patients survive to the immediate arrest, and 67% of those patients walk out of the hospital at discharge. That's what they saw from television. So that's what people are assuming happens, that you get really, really sick. They do this very aggressive thing, and then you get better. And in real life, that number is probably closer to 15% in all comers, and that's skewed higher probably for younger, healthier people with no comorbidities, and lower for older, sicker people. But 15% of all comers who have CPR actually survive, and that says nothing about their quality of life afterwards. So when I describe CPR, I use the big words, you know, it's the definition of death. This is how we will all die eventually. And I explain how CPR happens, that, you know, a team rushes in, they use their hands, they pump the heart because the heart isn't pumping on its own. And if we are successful, 100% of our patients end up in the ICU. 100% of our patients end up on life support, even though it's meant to be temporary, and sometimes it is. You can have broken bones. You might have some pain afterwards, but you can control pain. That's okay. We have lots of medications for control pain. The biggest uncertainty is the neurological outcomes. I cannot guarantee that a person will not have brain dead. I cannot guarantee that they'll be in a fully vegetative state. And I cannot guarantee that they won't come back to normal cognition. I just can't guarantee. That's a big unknown. And so if a person doesn't want to take the risk of having significant neurological impairment, then CPR should not be offered to them. Now, a bit of good news. Hospitals all over the world probably realize that this is a problem. And in Toronto alone, there's 4 or 5 different hospitals who all have different solutions. And COVID really brought a lot of this pressure to the surface, because now we were in a crunch for resources. And our hospital, Humber River, is no different. So the project that I led at Humber was really around restructuring the whole process of the conversation. So whereas before a patient gets admitted, they're acutely unwell, you have a conversation about goals of care, they come up to the ward, it gets documented wherever, maybe you have another conversation later, it ends up as a mishmash. What we did was we said, when a patient gets admitted to hospital, you should clarify whether they have any previously stated wishes, but if they don't, then you shouldn't have the conversation. Wait, get them up to the ward, get them clinically stable, and then consult someone else to have the conversation. And in this case, we trained the social workers. We would try to identify patients who would benefit most from the conversation. So we would look for patients who are high risk of clinical deterioration at 1 year. And we would say, this person's come in with CHF exacerbation. We should really try to prioritize this conversation, but let's wait until they're medically stable to have the conversation. The social worker comes in, and the social worker has what's called the goals of care values assessment. And we've created a template of questions that the social workers are trained to ask, and they document it into this form. They go through this goals of care values assessment. And after the social workers completed that, the physician can come in and they can complete the bottom part, which is the goals of care recommendation based on the conversation with the social worker. The other benefit is this note gets saved under its own heading. It's called a goals of care note. So it's easily searchable on future admissions, and it automatically attaches to the discharge summary, which means it goes automatically to the family doctor so they can see that the content was discussed and they can continue it. So that was the process that we established at Humber River, and we did it sort of as a quality improvement project. And it's still ongoing, and we keep making sort of iterative changes to improve it. Anyways, I'll get into some of the data around it. But from the list of problems that I came up with, well, this fixed the timing, because now they were closer to their clinical baseline and they were healing, and they were probably less likely to have their decision making obscured by acute illness. Now, with lack of training, we have deferred to social workers, and we've trained them specifically around having these conversations. And in general, social workers are probably better positioned to develop this type of rapport, and they do comprehensive psychosocial assessments anyways, and this really fits right into it. This standardizes the conversations, so it makes sure that any 2 patients hears the same information and can make decisions accordingly. Hold on a second. I'll get it. Just give me a few minutes, okay? And I'll get it for you. I'm taking you. I'll be just 5 more minutes and I'm coming out. Okay. Right. So standardization of the conversations. The idea of professional failings, inherent biases. Well, now we can make recommendations based on what the patients have defined as their own wishes. And documentation, of course, improves significantly. So there's always going to be system pressures. There's always going to be ethics and religion. Unfortunately, I can't really fix those problems. I won't get too into all the data for things, but I just wanted to describe a little bit of our outcomes. So we ran this as a pilot on 2 medical wards. We did 24 patients who we involved in this process. 9 of the 24 changed their directive from full code to something else. It wasn't necessarily, DNR, but we have a few different categories of what you can select in terms of your code status. And 9 of the 24 changed from full code to something else. So of course, this is important because it translates to savings in morbidity and healthcare costs. But that's close to 40% of the patients where we were at risk of providing a certain level of care that they wouldn't have necessarily wanted. So there's a huge potential risk to not doing this properly. The other thing that we saw in a very short pilot is that of the 24 patients that were included, 3, which is the little orange bar, 3 were readmitted. 5, which is the light blue bar, were admitted in the previous year, and 7, which is the pink one, had presented to the emergency room in the last year. So greater than 60% of our little pilot here had some form of interaction with the hospital in the previous or subsequent year. And that doesn't even include admissions to other hospitals elsewhere. And the reason that it's important is we were able to capture patients who are frequently coming to hospital. So a lot of the process was around saying, okay, we're going to defer the decision-making from this current admission, and we're going to focus on their next admission. If we can establish this thoroughly and properly now, then we can draw on this information at future admissions. And I don't have data for this yet, but I've certainly seen patients who've come back to hospital whose families have said, oh no, full code, do everything, where I can then pull up the note from the previous admission and say, you know, during our last conversation, they actually said X, Y, and Z. And the family says, oh, you know what, that actually sounds a lot like them. Okay, if that's what they wish, then that's just fine. So there's a lot of potential benefit to this. Most recently, we've been using a scoring system called HOMER. HOMER is the Hospital 1-Year Mortality Risk Score. It's a Canadian validated scoring system that helps you identify patients who are at risk of clinical deterioration at 1 year. And the reason this is beneficial is because now it doesn't require the physician to identify the patient themselves. Now we can use a scoring system, which is just one more objective measure to say, hey, this is really, really important and we should really be prioritizing this. And so we've integrated HOMER into our hospital system so that now at an organizational level, they can flag patients. And we can adjust the setting of the scoring system to change the threshold to either increase the number of patients we capture or decrease the number of patients we capture. We can also apply it to the outpatient settings through our clinics. But HOMER has been a really, really useful tool to sort of highlight if a conversation hasn't taken place up until this point, maybe now is the right time to have that conversation. And then the last piece that I'm doing now is, even with the change in process and even with the HOMER, it is still a high volume of work for the social workers and for the physicians to even engage in this process, because when done properly, these conversations really do take a lot of time. So right now I'm in the process of proposing a dedicated goals of care team that will roam the hospital, that will receive these notifications from our HOMER scoring system, and can then carry out the conversation in the place of the social worker and the doctor. And these will be a specialized trained team that can do this conversation again and again and again, document it properly, connect again as an outpatient, hopefully package up this whole process so that it's done in a more complete way. And that's really everything that I was going to say. That's everything that I've experienced so far in the field of goals of care and in internal medicine here in Canada.